Dr. Mark Epstein, who's the Senior Partner and Medical Director of TotalBond Veterinary Hospitals. He's also a Diplomate of the American Board of Veterinary Practitioners and is a Certified Veterinary Pain Practitioner by the International Veterinary Academy of Pain Management. He's also past president of both of these organizations. Thanks so much for joining us today.
Thanks for having me.
It's really a pleasure. We're really interested in talking with different professionals in the industry about the reason of why, kind of discovering the why behind why all of us joined the industry, started in this career, and followed our passion. And I know for you, pain management is one of those. Do you want to talk a little bit more about how you got interested in this and what's your driving force?
This was not this is no mystery for me. There was a moment that it occurred to me, and it had to do with a daughter of mine that was born with a cleft. And this was some 23 plus years ago. And at the time, I'll just report, not proudly, that veterinary medicine in general was not doing much with pain management perioperatively, postoperatively, osteoarthritis. So it just wasn't part of the culture, unfortunately. And she had a very difficult few days after that when she was only 4 months old. So it occurred to me, and that aftermath of kind of getting over that at 4 months old, her experience and the difficulty she had and the lack of understanding she had, and the doctors dealing with an agent, not the patient, him or herself, was mirrored what we have in veterinary medicine with dogs or cats. I mean, she was no more understanding of what was happening than any dog or cat might be. And that was the moment that I had that little revelatory aspect to say we need to do something different. So at the time, we just kind of started making stuff up. This was in the days before Rimadyl, so those who've been practicing that long will know that we weren't doing very much. And then Rimadyl was launched, and Diplomate was launched, and a kind of a pain culture became created, and the pharmaceutical companies deserve a lot of credit for having done that. IVAPM became into existence. I got involved with that organization, and kind of the rest is kind of history. But it's really, credentials aside and all that aside, it's really kind of a direct line between my daughter Hannah and me talking to you here today.
I think that touches a lot of us as parents, right? Mm-hmm. Because we can relate, and we certainly know that when our child is in pain, whether it's a human child or a furry child, we feel that pain too. And I think most of us in practice probably empathize with our clients when we're handling patients who have signs of pain. So when we're talking to those clients, what would you be counseling us that we really need to be asking in history questions that clients may not be recognizing that their dog or cat at home is showing signs of pain?
This happens all the time. So this is actually a reality that that the profession needs to kind of get a little alacrity about and really kind of open their minds about. Because patients will come in they may be older, maybe not, but they can say, how are we doing? Oh, she's doing okay, not jumping on the bed anymore, but it's not in pain. So everybody knows that drill. And we too easily can buy into that and kind of be distracted by the reality of what's going on with that patient. When it comes to osteoarthritis, these kind of chronic pain things, cats have it way more than we typically appreciate. Dogs have it way earlier and way more than we typically appreciate because they're conformational issues most of the time. So the answer to your question is that an entire team can become involved to recognize what are the historical signs, the physical signs. And so the historical ones are little comments like that, because in primary care, they're not coming to us for this problem. They're coming to us for something else, a semi-annual visit perhaps, and we have to recognize what it is that we're seeing and dealing with and proceed accordingly. But the team can be a role. The team are the ones that can see, there's atrophy on that back leg, or there's a straight-legged conformation, which typically ends up meaning the patient has shifted forward for a lot of years and has changed its leg conformation back here, that it's overweight. There are so many things that a team member can kind of pick up to alert us to the fact that we've got a bigger problem. Now, there's still a challenge because they're not coming in for this. They may be coming in for their annual or semi-annual visit. And we'd have to talk about teeth and lumps and bumps and ears and all kinds of things that we still have to incorporate. But there needs to be that kind of alacrity and begin these conversations with pet owners way, way sooner than we typically do. And that's our job. But it's not just the veterinarian, it's the whole team.
And how about not clear-cut signs of pain, right? Mm-hmm. So not eating as well or not grooming as well. What are other things that veterinarians and team members should be looking at, like you mentioned, the atrophy, during the physical exam?
Dogs and cats be a little different here. Yeah. Dogs are going to be historically represented by behaviors they no longer do. So owners are looking for things like limping. They're looking for vocalization, which these patients are often not doing. If it's bilateral disease, hip dysplasia, for example, or bilateral cruciates, they may not limp. They are going to be doing other things, limiting their abilities. The term that anybody can buy into, the veterinarian, his or her team, and the owner, is disability. That's what's happening. You don't see pain, even though the patient is exhibiting that or experiencing that, but you do understand that there's a lack of ability. If you have to help a dog up into the truck, how different is that than helping grandma up into the car? There is no difference. This is a progressive disability. If we kind of wrap our minds around it being that way, then we can begin to prompt the proper questions and the physical exam can proceed accordingly. Now, cats are a little different. Their main criteria is going to be more of a stilted kind of a gait, it's not fluid, and a lack of jumping. So if we get, just to give you an example, if we get a question like, how's she doing at 10 years old? She's doing great, I can't tell a thing. Funny thing is, she's not jumping on the counter for food anymore. I finally taught her not to do that, after 10 years. Well, of course, it's not that you finally got it through her head, it's just that she's not going to make that leap anymore. So a lack of jumping, frequency of jumping, lack of nighttime activity, those are the kind of the criteria we come across with the cats.
That's really good to know, because I think a lot of people still think that cats are small dogs. We know that there's a lot that is no longer true. Right. I want to touch base, though, again, a little bit more on what you said about team, because I think in today's industry, a lot of the veterinary technicians and nurses still feel underutilized or maybe not as empowered in their role in some small animal practices. And so how can a technician start to elevate themselves in the role of pain management or as a pain champion in the practice?
I'll move it up to the front desk, because they're the ones that hear these kind of maybe incidental comments that owners will make. They're the ones watching as it gets escorted around, right, to the exam room. So they can see a short step. That means there's a lameness in the opposite joint. They can see the confirmation. They can see the body condition score that's too high. They can see the inability of the dog to get up clearly with all four legs at the same time. So they get up on the front leg and hoist the back end up. So they can see that stuff as well as anybody. Technician obviously can do that as well. Technicians can also, however, get a little bit more in tune to some specific confirmation things, and they can run their hands over animals as well and begin to pick up maybe the proper term would be asymmetry. So if two elbows, just one feels different than the other, it's probably because one is thickened. Stifles, medial buttress, they don't have to know exactly why a medial buttress forms, but they can certainly pick up that there's a difference between these two. Just as they're getting the temperature, getting the weight, they just run their hands over these animals. So the kinds of things that can be alerts for the clinician to come in and begin a conversation in a different way are monumental. So they are essentially what is happening is that the physical exam is beginning out in the reception area, and it continues through into the exam room with the technician. Finally, the veterinarian comes in and actually does the formal one. But the whole team can pick up elements and pieces historically, confirmation, gait, and even physically.
I'm sure you work with a lot of different veterinarians around the country and different hospitals, and I'm really curious as to what's one really good area of opportunity that practices can start with if they feel they really want to take the next step to elevate their pain management protocols or the management of their patients.
I think I can answer that one pretty quickly too. And having just given some talks here, I take a straw poll when I get to a section of these presentations about local anesthetics. And I can ask a room full of veterinarians or technicians, frankly, because it's usually a mixture. How many of you are using local anesthetics right now in practice? And most hands will go up, thankfully. 10 years ago, not many went up, so that we've made progress. But if I follow with saying or asking, how many of you are deploying or using local anesthesia or local regional anesthetics every time you lay a blade to skin? That is every surgery, every surgical procedure. 15%, maybe 20%. So there's a great opportunity here, because in humans, it's nobody has a procedure without a local, right? It may just be a little incisional, it could be an epidural or something in between. It's so standard.
And where can a hospital go to have more training in that? What's a good resource for them?
There are two different ways to answer that question, and one of them is that there are many, probably every major conference, somebody is giving a talk on locals. I mean, because that, like I said, the train has left the station and people are hungry for the information. So most of the time you can get it if you're going to a big enough meeting. A little kind of a next level up, though, is wet labs, where you actually get the didactic and watch the video techniques and you have the handouts, and then you are in a cadaveric wet lab, and so you can practice them with a team of people. And several conferences are doing that as well. I do one with ABVP every year, but they can be found, including at Western, I believe, with some regularity. And that's the next step up. Now, there's one more tier, and the next tier is to not just kind of use blind techniques and palpation to kind of place your needles, but it is to learn nerve location, to do regional nerve blocks. Now, this requires some tools and some training, so either electro nerve location or ultrasound guided location. That's a whole nother dimension, but it's like the next up. So you asked, and it can be stepping up to wet labs and then up to live animals and doing ultrasound and electro nerve location.
You've been a wealth of knowledge and certainly puts everything from the practical day-to-day, how to get our team involved, but also how we can elevate to next level depending on your interest and how much you want to excel at this. But thank you so much for sharing your story and your expertise in the industry, and I hope you have a great conference.
Yeah, thank you, and pleasure's mine.